Welcome back, everyone. I'm Nigel Edwards. I'm a senior fellow at the King's Fund. I'm chairing this session. This is a panel session with discussion and I hope audience participation. We'll get some opening statements from the panel, but I'd like to, and this is a note to the microphone people, I'd like to involve the audience fairly quickly if we can. We've got till 12:10, so when you do intervene, however, short and to the point would be greatly appreciated, and will mean that I don't have to be brutal, which would be good. So the topic for the next session is the challenge of quality, and I'm joined by a very august panel. Professor Al Mulley. I'm not going to read the biographies, by the way. They're in your pack. You can look at them. Time is short. Professor Al Mulley from Dartmouth, Dr. Penny Dash from McKinsey and Company, who's also vice chair of the trustees of the fund, and Professor Sir Liam Donaldson, who doesn't actually. None of these people really need any introduction, so I'm, as I say, not going to do that. So the topic is the perennial challenge of how to improve quality in the system, and it's rarely out of the news, but we have had a whole series of very disturbing reports about not just healthcare quality, but as we've heard today, quality in care for older people, in other sectors as well. We should be expecting the Francis inquiry in the next few months, which will give further impetus to the search for quality. And of course, we've had 3 reviews of regulation in 12 years. I think with the CQC currently having a further examination by the department, unlikely, I think, that Francis won't be saying that there's further regulatory change required. So we're on the search for the right model of regulation. And of course, the QIP, the Q in the QIP challenge, a very important part of that, but a sneaking anxiety, I think, amongst many of us that the evidence that high quality care is always cheaper is rather subtle, and it isn't always so, and that it's much easier sometimes to make efficiency savings which don't do much for quality and indeed might endanger it. So there's a whole set of pressures there. In the longer term, though, the context is that we've got continued evidence of quality issues. Our internationally outcomes in important areas still it's a disputed area. It may not be as bad as we're told, but it's not as good as it should be. That's certainly true. And still very significant variations in quality and outcomes between areas, which are hard to justify and certainly a big concern. And internationally, and in this country too, that's set against the background of a growing pressure for transparency, for the publication of information, for people to be open about how we're doing and what we're doing and whether we're doing the right thing. And that's unlikely to be turned back. I think, if anything, that's going to get more intense. And at some point, although the evidence suggests it's mostly the providers that look at it, it seems very likely that that's going to change, and we will have to start to live with working in a very transparent environment where there will be much less tolerance for poor quality, for the high levels of variation, and where policymakers will start backing that public interest up with payment systems and regulatory mechanisms that start to hold people's feet to the fire in a way that will be difficult and uncomfortable, I think. So, but even if that weren't true, there is a moral and ethical imperative to get this right. So my panelists are going to help us through some of these difficult questions that we've been set, and I'm going to invite them to make their opening statements, and we'll start with Professor Mulley with perhaps a bit of an international perspective as well. Al, over to you.
Well, I'm going to focus on the question: what are the barriers to and facilitators of high quality patient care? And I'm going to be somewhat general in my response to that, hoping that we can dive down into more specific examples during the conversation. And with that, I would say that an important barrier to achieving both quality and patient-centeredness and efficiency as well is failure to acknowledge the complexity of medical care. By that I mean there's too much if-then thinking in healthcare. We want to believe that if we deliver a particular intervention, it will achieve a particular result, and that result will be valued by those who receive the intervention. When in fact, as all clinicians know, there's a great deal of uncertainty between the intervention and the result. It may vary. There may be a great deal of uncertainty for some interventions, less for others, but there's almost always some uncertainty. And also, patients disagree about the value of particular results. I think if you consider the men in this room, the women in this room, the people in this room, it becomes obvious that if interventions involve trade-offs between different domains of health, or different physical functions, or different social functions. In other words, you get benefit in one area, but you receive a complication that decreases your function in another. People are willing to make different trade-offs under those circumstances. So this uncertainty and disagreement contribute to a great deal of complexity, and when we revert to the if-then thinking, it's often wishful thinking and wishful doing in healthcare. Now, it's this complexity that underlies the phenomenon of practice variation. And as I think most of you recognize, the phenomenon of practice variation is quite controversial. Clinicians often respond in a somewhat defensive way. But if you acknowledge the uncertainty and the disagreement, then practice variation becomes a great resource for learning. One way of thinking about practice variation, and the reason it's so controversial, is that if all practice variation were bad, then it would be an easy problem to solve. We would just tell clinicians and we would build systems and eliminate practice variation. The trick is to sort out the bad variation that reflects poor knowledge management or uncertainty that doesn't have to be there when the decision is being made, from the good variation, which often reflects the different trade-offs that patients are willing to make. So I think the barrier is, the most important barrier is failure to acknowledge complexity. When we do that, we think a little bit too much, and forgive me if there are architects or engineers in the room, we think too much like architects and engineers and think that we can define processes that will deliver quality and deliver patient-centeredness. When we over-specify such measures, we risk creating a kind of box-ticking response on the part of physicians, and as you know, there are many who are concerned about that driving out intrinsic motivation to achieve quality, to give patients what they need and no less and what they want and no more. So I would argue that we need to go deeper recognizing the complexity and create some measures of quality, not so much for judgment, although to some extent, but for improvement in transformative ways. And those measures would be more aligned with the sources of intrinsic motivation and more consistent with the values of the profession. So we can talk a little bit more about that later, but what I'm referring to are measures of sharing knowledge among clinical team members, sharing knowledge between clinical team members and the patients in the communities that live with the consequences of the care that is delivered. And also measuring the quality of decisions. Are patients informed? Does the care provided to particular patients match what they care about in life? Their utilities, their risk attitudes, their discount rates, to use the language of an economist, what this illness, its treatment, and the outcomes mean in their life, to use the language of the social scientist. So that's what I think is the principal barrier. Now, the principal facilitator, in my view, is willingness to question assumptions. I think our last presentation from Dr. Ravindran was a challenge for us to question our assumptions about how care can and should be delivered. Colleagues of mine at Dartmouth talk about organizations and leaders of organizations having to allocate their time and commitment among three boxes. Box 1 is managing the present. Box 3 is creating the future. Box 2 is discerningly, selectively forgetting the past. So you have the vision and the room to create the future. I think that that's all about questioning assumptions about how we do things and how we could do things. And I think we can ask that same question about Box 1, Box 3, and Box 2 about the quality measures that we develop and apply. To what extent are they focused on managing the present? To what extent are they focused on creating the future? And how do we think about what we need to forget about the past in order to create some new quality measures?
Thank you. Where do you stand on the question of whether measurement for selection and performance management drives out improvement, which is the sort of the Don Berwick position? Is it Goodhart's law that says that the value of any information declines to the extent to which it's used for those sorts of purposes?
I mean, that's one of the problems I'm referring to with the overspecification. If you specify processes with this if-then thinking, you do move people's intrinsic motivation to the periphery, and you do have them ticking boxes and following processes without acknowledging the complexity of the uniqueness of the patient in front of you at the time. And I think what draws most people into the healing professions is being able to deal with the uniqueness of individual circumstances and the context they bring. I think that there are examples in long-term conditions, since we were focusing on that this morning, where an individual with a single long-term condition like diabetes might have 5 or 6 tasks that the clinician would like them to perform. If they have a second or a third long-term condition, there are 10, 12, 15 tasks. Neither patient nor doctor are willing to acknowledge the constrained resource of time that they have. So it's sort of a random walk among the tasks during the particular visit. And interestingly, the evidence would help you set priorities among those tasks. But the priorities set by the evidence would then have to be reordered by what this particular patient can do easily and what this particular patient can do with great difficulty. We move dramatically away from that kind of personalization of care, patient-centered care, when we encourage people to tick boxes and focus on processes.
So defining value from the point of view of the patient.
Yes.
Great. Okay, well, I think that's a theme I'm sure we'll come back to. Liam, over to you.
Thank you, Nigel. Good morning, everybody. As we all know, the NHS delivers variable standards of care, and we can see this if we look across the country, within localities, within fields of care, and even, very fascinatingly, within individual episodes of care, where somebody can be exposed to very dismissive attitudes, but at the same time can technically receive a very good outcome of care. That variability taken right down to the micro level is the thing that I think is the most frustrating of all. Errors are common and continue to harm people. In my role as chairman of the National Patient Safety Agency, they come across my desk every day, serious harm, death, and in respect of this variation in quality and poor record on safety, the problems aren't unique to the NHS. They affect most other healthcare systems, but they've proved in most countries, and in this country as well, very intractable over the years. They're deep-seated problems, and no single or simple intervention can resolve them. So we've been asked just to talk for 3 minutes, and I thought I'd just highlight 3 areas where they're not the only areas, but 3 areas where I think we need to go much deeper in our action to address quality and improve safety. The first is the area of the ethos of professional practice. And I'll talk predominantly about the medical profession, though other professions are clearly in a similar position. But the perspective of medical practice is quite narrow. Traditionally, and it still applies today, doctors see themselves as caring for the individual patient, and that's quite right and proper, and it's a very important part of quality care. But they don't see themselves really as needing to have any appreciation of the risks of their practice, of the wider aspects of quality that surround their practice, or the need to regularly seek opportunities for quality improvement. That's somehow seen as a separate managerial activity, not an integral part of professional practice. And that spills over, I think, generally into some quite negative features of the current professional ethos. My work with the World Health Organization on patient safety has led to us, as many of you know, introducing a surgical checklist. And the early evaluation of that checklist has shown that if it's used properly, it reduces post-operative mortality and morbidity. And it's in pretty widespread use around the world, including in this country. But I regularly hear anecdotes as I travel around the country of, for example, surgeons scrubbing up on their own and refusing to participate in the checklist because they feel it's a trivial and meaningless activity that isn't, they're happy for their team to do it, but they don't want to do it themselves. And it strikes me as very surprising that is not seen as poor professional practice, but it isn't seen as poor professional practice. Similarly, as some of you know, I've had a team of young doctors who were working with me when I was Chief Medical Officer. We called them clinical advisors. They got a great deal of exposure to the concepts of safety and quality and health policy. Many of them have then gone back into clinical practice and found a very hostile reaction to the new skills and attitudes that they've learned. In one case, one of my doctors was given a very severe dressing down for reporting too many incidents because it was felt that he was showing the hospital or the department up in a bad light. So those sorts of features let me think there's been a lot of talk about the new professionalism, but I still think it hasn't yet captured the essence of what needs to change in professional practice. I think there's great hope for the new generation of people who are coming through. It seems to me there's a critical mass of people who remain idealistic despite the tendency of medical education to beat it out of them. And we need to, I think, do two things. One, build a leadership cadre for the future out of this young generation. It's been very striking to me, Nigel mentioned some of the scandals that have come out over the last few months. It's been very, very striking to me that there have been virtually no national voices calling for, in leadership terms, calling for the sort of soul-searching and change of emphasis that's needed as a result of this. The voices have tended to be from patient representative groups. And I think also it's very unfashionable in quality terms to ever talk about education and training as playing a role there. That tends to be seen as a separate activity with its own bureaucracy. But I think the fundamental challenge would be to try and address some of the problems that we see through a fundamentally different approach to education and training, which is no longer unidisciplinary or uniprofessional, which brings patients and families into the educational process as partners, and many other things as well. The other 2 points I'm going to mention much more briefly. I lament the failure over all the time that I've been in a professional role and a managerial role in the NHS to take information seriously. And without data and information of very high quality, we will not be able to transform the quality and safety of care. Those receiving care and those providing the care are largely in the dark as far as objective information on whether the service they are getting is good, bad, or indifferent. And we really need to do something about that and get serious about data and information. And then my third point is that I've seen many examples around the world of health services and particularly individual institutions making very heavy use of patients and families in the way, not just getting feedback on their services, but making them, getting them to play an integral part in the design and structuring of services. I don't think we do that very well in this country. There are some notable exceptions, but I think we need to get much more deeper and more serious about that. Finally, I haven't mentioned organizational culture because I thought everybody would groan. Nobody has a solution to it, but we've seen examples pouring out into the media over the last year with Mid Staffordshire, with many of the other particularly services for older people that have been identified. And somehow we need to crack that problem of understanding how to produce positive change in organisations and know when we've done it.
Does there come a point where you give up and start again?
Well, I think at an institutional level,
that's what I mean. Yeah.
I think. But having said that, I vividly remember when I was when we set up the clinical governance team in the late 1990s. Talking to somebody who had turned round a mental health service. It was one of these prize events, I think it may be the HSJ, I don't remember. And she told me that they'd had a desperately bad service with patients being abused. I mean, it was as bad as it got. And I asked her, in turning it round, which they had, and they'd done a spectacular job, how many staff they'd had to get rid of. And out of something like 20 staff, only 2. And she said some of the converts to the new way of working were the most, resistant people and who'd been very involved in the old culture. And that was a revelation to me, that you could use the same people through skilled leadership and transform their attitudes and hold a mirror up to them and show them that there was a different way of working. So I'm traditionally a bit Stalinist about those things, but having listened to that story, I would say you might be able to transform whilst keeping much of the same team in place.
So, important role for leadership to remind people of what professionalism is about. Leadership both at the individual organisation level, at the team level, and at the national level, you're also saying. So there's a wide range there, but a very similar theme, I think, to Al's one about really moving from a sort of to a system based on the value we add to the patient and dealing with the goals of the patient rather than the problem. But Penny, I think you're going to talk particularly about regulation, but I think we'd be interested in your more general thoughts as well. So over to you.
Yeah, I'll try and actually I think it'll build very much on what Liam said. So I just want to start though by reminding ourselves about what do we mean about quality. And I think one of the very positive things that happened here in the last few years, and Liam played a big role in, was actually defining quality and defining it as the 3 domains of, first of all, safety. How do we make sure that checklists and so on are in place? Outcomes. Do we actually get better? Do we have a good result? And then the patient experience, because I think it's important to think of it in terms of those 3 domains. What is it that we all aspire to for ourselves, our families, people we know, for the 60 million people who live in this country and globally? First of all, that safety we can take for granted. So in exactly the same way as we all say, when we get on a plane, we are taking it for granted that the engineers looking after that plane have gone through those safety checklists. And as Liam said, we should be able to take it for granted that that happens automatically in every single hospital, and that every single GP has been through a proper registration process and is up to date, who knows how to manage all the regular conditions and so on and so forth. That ought to be the absolute norm. It is a long way from being the norm, and that's, as Liam said, not acceptable. The second is clinical outcomes. I hoped when I had children several years ago, I hoped that I would have a midwife who would deliver those babies with minimum amount of perineal damage. I hoped that there was an obstetrician who was a fully qualified and experienced, had been an obstetrician for at least several years, had been fully trained up, who was there available in the hospital that should something go wrong, that he or she would be able to rapidly intervene with fully qualified obstetric anaesthetists and everyone else there ready to go in order to ensure that my babies were born with an APGAR score of at least 8. That isn't the place in probably 50% of hospitals in this country at the moment. I would hope that when I take my children to hospital that they're seen by a fully qualified paediatrician if they're acutely unwell and they're properly managed. That doesn't happen again in about 50% of hospitals at the moment. I would hope that if I had a stroke, I had rapid scan and rapid thrombolysis. I would hope that if I had a heart attack, I had rapid primary angioplasty, because we know that those things essentially improve our survival by about 2-fold at least, or at least enable us to walk out of hospital rather than be sat in the corner in an armchair for the rest of our lives. I would hope that if I needed abdominal surgery, that the surgeon there in the hospital, particularly if it was an emergency, was fully trained up in laparoscopic surgery. I would hope that if I was in a major car crash, I was taken to a hospital with all of the teams there to put me back together again. And I would hope that when I'm demented, that I'm looked after by staff who know how to treat me with courtesy and so on. And I would hope that I had a GP who was able to coordinate the services around my needs. And on top of all of that, I think it is, I would hope and expect that the experience around all of this, so the patient experience, that people treated me with civility, gave me a drink, and all of those very basic things that we would expect someone in Starbucks coffee shop to do for us, and they largely do for us, and we complain if they don't do for us. So we could all sit here, we can all recognise those. As I've said, that doesn't happen in more or less half of hospitals in this country, and probably in more than half of GP practices. So, as Liam said, we need a leadership that is willing to tackle that. In the last 6 months, I've sat in on around 10 Foundation Trust board meetings. All of those Foundation Trusts have areas where some of those aspects that I've mentioned are not currently being delivered. Not one of the boards has discussed it. So despite the fact there have been papers there that you could have dug deeper into, in general, the medical director says quality of care in this hospital is very good. We frequently do audits, and the board nod and say, yes, it's very good. Only on Monday did I point out to the governors at one of these FTs that they don't have a primary angioplasty service. And this is an FT in a part of the country with a very elderly and affluent population, and they fell off their chairs. They said, but we've always been told that cardiac services here are very good. I said, some aspects of them are, but you don't have primary angioplasty. This hospital does not do primary angioplasty, and it takes patients having acute cardiac events are admitted to that hospital. They were gobsmacked to hear that. No one had ever told them that before. I've been to other hospitals where they've had all of the patient experience data there, clearly shows that they are at the bottom, i.e. they are in the bottom decile of patient experience data. Again, this is a leading edge Foundation Trust who rated themselves very highly in terms of their quality of care. And the board turned to the nursing director and said, this doesn't look good, what are we doing? And she said, we've sorted it all. And we moved on. At the end of that particular board meeting, the new non-exec said, when we were looking at some of the HR data and we were looking at data about recruitment and so on and so forth, the new non-exec said, and when will we see the data for how many people we've removed from this organisation? And the HR director said, we don't collect that data in the NHS because we don't remove people. We only remove people if they have sex with a patient. And this new non-exec said, well, but we've just been talking about some quite poor quality patient experience data. Surely you found, Liam said 2 out of 20. He said, I would expect in any organisation to find a bit less than that, but 1 out of 25% of people who weren't really delivering the sort of quality of service that I would expect, whether I'm in Starbucks or John Lewis or British Airways or whatever. And again, the HR director said, no, we don't look at it in that way. So I think, where does all this take us? So where this takes us is, exactly as Liam said, we actually have an awful lot of information. All of those areas that I mentioned, we have information to say, are hospitals, are GPs, are community staff actually delivering against these, what we know are expected standards of high quality care. We have the information to look at that. We could have a CQC that put all of that information in the public domain tomorrow, and it could be on headline news tomorrow night. There's absolutely no reason why not. We could have boards that ask to see that information, and we need to go through a rapid step change process of having boards ask for that. The board at Mid-Staffs did not ask for that over the last 5-10 years. They do not ask for it now. They don't realise that they're still not delivering high quality care. And as many people know, and hopefully the Francis Inquiry will expose this, they were not unique. And they are not unique now by any means. So we need to, first of all, put the data in the public domain. We need people like the CQC and so on to make it accessible, to explain what it means to people. We need boards of hospitals to start to question this, to start to challenge this. And most critically, we need the equivalent of a board for out-of-hospital care. Because at the moment, we only have a management and a governance structure around the 50% of healthcare activity that takes place in hospitals. We have absolutely nothing for outside of those hospitals. So that's how I would start to tackle some of the system and regulatory issues.
Thank you. But apart from that,
yeah,
it's all going terribly well. I think you'll agree. I think you've raised some really interesting additional points there, which we might just explore from it. You mentioned care coordination, and Al, you were sort of alluding to that as an issue as well. I mean, have we been neglecting that? It seems to be across Europe the puzzle of how you coordinate care within hospitals, but in particular between hospitals and between specialists. A chief executive of one integrated trust just told me the other day that she's discovered that she's got physicians prescribing medicines to patients, which mean they get 6 visits at home a day from different nurses with providing different medicines. It would be cheaper for them to be in hospital, but in terms of the risks and the costs and the experience of the patient, I mean, have you got some help for us here? Because I think it's probably one of the key challenges, isn't it?
It is one of the key challenges. I think care coordination is a universal problem. There are places that have done it extremely well, and that is usually involved matching tasks to skill levels, as we saw in Aravind. I think that teamwork in general is an area for improvement in virtually all healthcare systems. We've been very interested in the extent to which you can measure teamwork, and there are various measures that people have developed to do that. I've been particularly interested in one developed by an American colleague by the name of Jody Gattell, which he calls relational coordination. And it's basically a measure to determine whether or not members of a team, in this case a clinical team, be it the consultant, the GP, the nurse, others, and even community health workers or coaches, all have the same knowledge, shared goals, and mutual respect. When you measure this relational coordination, this aspect of teamwork, it has a dramatic association with better results. In other industries as well as healthcare. She began her work in the airline industry. It takes shared goals, shared knowledge, mutual respect among pilots and people who get the patients, the customers on the plane, the baggage, et cetera, and those tasks are interdependent. And if they don't have shared knowledge and don't have mutual respect, the interdependent tasks just don't get coordinated. And I think we all recognize that as a problem in healthcare. So we're actually working hard to bring measures of relational coordination among teams, also because we think that if we can demonstrate the importance of shared knowledge, shared goals, mutual respect among clinical team members, there's greater likelihood that those clinical teams will recognize the importance of having shared knowledge, shared goals, and mutual respect with patients and the communities that receive the services.
Yes. And indeed, if they're doing the checklist together, I guess would be another example of that. Okay, I think we could probably invite. We have some microphones. Yes, we do. So I think it's time to invite some comments. I wouldn't mind picking up the human resources management bit that I think there's someone here. We could get the microphone to that Penny picked up, and at some point we might ask you, those of you who work in trusts, what your appraisal rate is. So you might want to think of.
Thank you, Ian Whitey from Royal College of Obstetricians Gynecologists. I always have a problem with the airline or the pilot's analogy because, of course, if the pilot doesn't do the checklist, the pilot dies along with the passengers, which is not the case. And it brings me to the point, interesting point, and I think anybody who's watched, as I have, an elderly parent die in hospital wouldn't have been shocked by the recent reports coming out about the quality of care for elderly patients. What is really despairing is the number of relatives who say they didn't want to make a fuss because they were worried that the care would get worse. And I think that's absolutely outrageous, that people feel that actually, if they make a complaint, harm will be done to their patient. I had a problem with my car and the service. I complained about it, but I don't expect that they put a note on the car saying the next time this bloke comes in, loosen his wheel bolt so he crashes on the way back. But that is the situation in so many places, and until we change that power relationship, I don't think much is going to change for the patients.
Thank you, Ian. We'll take a couple of comments. There's David Fillingham there. Anyone up there? Yeah, we'll come to you in a second. Sorry, I hadn't seen you. You're somewhere in the distance there. Thank you. David.
Thanks, Nigel. David Fillingham from the Advancing Quality Alliance. Wanted to pick up the point I think all three speakers mentioned about the role of involving patients and the power of involving patients, both in real, genuine choices about what care they receive and also organisation about how we redesign services. And it seems to me we've been talking about that for at least the 2.5 decades I've worked in the NHS. And a bit like the last speaker, somebody who's had elderly relatives through the system, it doesn't feel as though we've moved very far. And I guess that's because what's really needed is a fundamental shift in the balance of power between professionals and patients and between institutions and patients. And there are a lot of barriers to that. So I was hoping the panel might have some suggestions about what we might do. It seems to me that the answers obviously lie in some of the softer issues around education, around leadership, around cultural change. But you invited us to pick up the HR issue, Nigel. I think they also lie in slightly harder-edged things around incentives and penalties, both at an organisation and an individual level. Not so much around clinical competence, but around behavioural standards and around the level of compassion we show to our patients.
Yeah. That's a hard question, so we'll give the panel a minute to think about that, and we'll take one more question or comment from up there. Just say who you are for us. And
I'm Mark Rickenbach. I'm a Professor of Healthcare Education and Quality at the University of Winchester and the Wessex Deanery, and a GP. And the point I want to ask the panel is about collation of feedback, because there is a massive amount of feedback that could potentially be obtained on the quality of care within the NHS. Every healthcare worker, every doctor, every day can see problems within NHS and generate solutions for those problems and has them at their fingertips and in their mind. But we don't collate this. We have a tip of the iceberg, which is seen as whistleblowers, but there's a whole massive information. So how does the panel think they could put in place a practical system that would collate this information, look at the feedback, and then act on it effectively? Thank you.
Well, I think all three questions are really converging on the same theme. So, changing the balance of power, your question really was about the constructive use of feedback. What are the measures that we can take to shift the balance of power? I think those are all really in the same territory. Liam, would you like to take that on first?
No, they are very, very important questions, and in limited time available to do justice to them all. But very briefly, one of the things that I found very striking travelling around the world is the extent to which a single case tragedy, usually involving unsafe care, in some institutions is totally transformative. The institution, or you can almost see them changing in order to honour the memory of the person that they've killed. And in others, they move on with an investigation, an inquiry, a bureaucratic list of recommendations, and nothing changes, and you feel the same thing could happen again. And I think the point about the disempowerment or the powerful role of patients and families, it is absolutely fundamental. One small but important thing that I think we could do, coming back to the educational thing, is to think not just about minds in education, but about hearts as well. And I've seen some very striking examples of where patients, relatives of people who've been killed in hospitals have come in to give their testimony to students, and it completely transforms their view of the world, seeing it through those eyes and the tragedy they've experienced. So I think that's one positive thing that can be done. But as far as the wider question of patient involvement, go and look at a hospital like the Dana-Farber Cancer Institute in Boston, who killed the reporter of the Boston Globe with a maladministration of cancer drugs, and then nearly killed another patient with the same technique. And they have completely put themselves into a position where family members and patients are so integral to the running of the service that they can't remember a world without it. And I think that's a very good example. On the feedback, very, very briefly, I think on the patient safety front, we don't do enough of this. We're not picking up the insights that are there at the grassroots level, and I think in the future, as the system moves into a different way of being managed, we need to do that much better.
We're still bad at whistleblowing, I think, is the penny.
I think, there's lots and lots of things that could be done around all of these things, but I'll just pick up on one thing, because there's a slight flippant comment you made to Ian about appraisal. Well, actually, I think appraisal...
Oh, I don't think I was being flippant. I think this is a big deal. Right?
Well, so I would say, I think in some ways we could really, really fundamentally change and use appraisal to start to drive a lot of this. I spent the first 10 years of my working career as a doctor, created a bit of noise, like Liam's saying, with some of the junior doctors nowadays, got a bit of, flack from trying to challenge some of the things and so on, and sort of quietened down, and that was it by way of feedback. In general, if you were bright and you came here and you passed all the exams here, which I did in this room, then, you did well, and that was it. I then went out into management consultancy around 15 years ago, and then I had appraisal. And my appraisal then, and still now, is based around defining what does good look like. And it is really, really hard-edged, and it takes place every 2 to 3 months. It involves, A, does the client, does the customer, does the patient actually think you're any good? I'm expected to solicit feedback on a regular basis, and other people go and solicit that feedback for me. So it is actively there, it is measured, and it counts for whether or not I am still in a job. I'm expected to be able to think clever things and write clever things and so on. That is actively measured, it's collated and so on. I'm expected to provide leadership to my teams, I could go on. There are 5 domains, and within each of those 5 domains are 10 measures, and each of those measures are clearly set out, and I'm given a score on each of them, as I say, every 2 to 3 months, as is everyone else in the organisation, from the secretary to the person who runs the photocopying machine to the boss and all the rest of it. And I compare that to the way in which we continue to assess and appraise doctors, nurses, managers, and it's light and day. I think if we started to appraise people on the things that we think matter, like involving patients in their care, like getting feedback and doing something with that feedback, like delivering best quality care and learning what is the latest standards and so on and so forth, that would revolutionise things.
Just quickly responding to David, relational coordination measures are about knowledge power hierarchies. It is about the person with the highest level of training not seeing their role as being the sole heroic decider and doer, but the person who has the most responsibility to be generative in sharing knowledge down the line of training so that the team can work in a coordinated fashion. And then the argument that I made at the end of that was to say that if we do that among clinical teams, the clinical teams are much more likely to behave that way with patients. And again, achieving shared knowledge, shared goals, mutual respect with the patients and the communities that they serve. Now, one measure is the measure of teamwork. The second measure is the measure of decision quality. It's what shared decision-making is all about, right? It's shared knowledge, shared goals, mutual respect between doctors and patients. Doctors recognizing that they have the professional knowledge, but the patient has the unique personal knowledge that determines whether or not this knee operation is right for them or not. And Liam and I have talked before about patient safety in this context. Is it more of an error to operate on the wrong knee than to operate on the wrong patient, one who is so poorly informed that he's getting that operation and he would not have chosen it if he had been informed? So, and then the feedback question is, if we really did measure how informed patients were and the extent to which clinical teams gave care that was reflective of what they cared about, this whole notion of value concordance, where you see 7 times greater rates of surgery among people who feel this way about their urinary symptoms as opposed to people who feel this way about precisely the same symptoms. If we did that, we would then have feedback that would tell us what the true demand of patients is for different services through their revealed preferences. That feedback would help us right-size capacity to do different things in the system and achieve efficiency that no healthcare system has achieved to date. So I really do think it's about knowledge power hierarchies and developing the measures we've been talking about and the next stage review measures. Those are about managing the present, and we should put 90% of our effort in. But if we want to see transformation in healthcare, we ought to be thinking about some measures that will deal with knowledge power hierarchies.
And what should we select to forget? Just notice on the questions for the rest of the panel, that will perhaps what we'll go out on. I think we've got time for a couple of quick points, as unfortunately right in the middle of the block. So there's a gentleman here, and yeah, I don't know if we haven't got a second one in that area. Yes, go. Thank you.
Mike Gretton, Chairman of Winchester and Eastleigh Acute Trust, so a slightly acute-centric point. To answer your question, 70% of the recorded appraisals and recently adapted to be reflective of the values of the trust, which include quality, safety, patient-centric, etc. But we're not there yet.
That's pretty high, I think, if I remember rightly. But yeah,
it's where we are, and we've worked very hard at it recently. My point really is for Cillian. I couldn't agree more with your point about the ethos of medical practice at the heart of this. I believe that's my responsibility in my trust, and we work very, very hard at it. We're not all there. What I'm interested to know is how can the system as a whole support people like me and the board to generate that ethos. You referred to a couple of things of educational, but that's quite a long way away from the centre of what we're trying to do.
Okay. That wants to be a quick answer. Well, before we take it, you got the microphone? Yes, sir.
James Ray, Chief Exec, Central London Community Healthcare. I wanted to pick up Penny's point about governance and accountability in the community. I would hazard a proposition that I think it's beginning to be there for mental health services. I think they're organised in a way in which there are boards, and what good looks like is better defined now than it's ever been before, and therefore you can begin to go with the grain of your comments. I think there is a real challenge for the rest of us in community care services, and I wouldn't just count community healthcare services. I think social care, I think to a degree primary care, though it's better defined there as well. We haven't defined or agreed what good looks like, and the comment I'd probably ask you to make is, do you think clinical commissioning groups, health and wellbeing boards present the opportunity for some governance over that? My third and final point would be, take the challenge about appraisals and human resources management, but where are professional standards? Where do professionals hold each other to account for the clinician who doesn't scrub up or follow the list or doesn't comply with the guidelines? When do peers begin to challenge one? Thank you.
Okay, lots of big questions there. Time is very much against us, so I've asked the panel to be to pick and choose amongst that. And you might, if there's something you think we should begin to forget, that would also be useful. But
okay, on the support for the good work that's going on in places like Winchester, I would say the new professional ethos. Let's see a letter to the Times before it's closed down by the Leveson inquiry, signed by the presidents of all the Royal Colleges, setting out a vision for a new ethos of professional practice, recognising that the present one isn't adequate to solve some of the problems we're talking about. I'd be happy to draft it. Whether they'd be prepared to sign it's a different matter.
Yeah, well, I fear we might know the answer to that, Liam. And that might be one of the things that we're selectively forgetting there too. So good. Al?
I think that the selective forgetting is in the domain of the heroic decider and doer, being the person who is most esteemed in medicine, as opposed to the person who uses the knowledge in a generative way, to create teams that can create value for patients.
Great. Penny, you get the last word.
Okay. Well, I'll come back to try and bring it back to the reform question. I think the clinical commissioning groups could have done it when they were GP commissioning groups, and some of them were just starting to, as you saw, I've seen a bit. I worry now that it's become as diffuse as a clinical commissioning group, you will lose some of that. I think one of the biggest problems, which Liam touched on it, I'm still amazed at how deep it is this cultural sense amongst not just doctors, nurses and so on, that you don't shop on one of your colleagues. It's a very, very, very deep-rooted culture. And the number of hospitals that I go to, the numbers of GPs, particularly in hospitals they do it, where someone will, the medical director will openly say something like, well, of course, I'm a geriatrician. I couldn't possibly comment on the quality of the orthopaedic surgeon. And I'll say, well, I stopped doing clinical practice 15 years ago, and I'm very happy to look at their post-op infection rate, whether or not people can walk, what the problem status says, and all the rest of it. Why aren't you happy to look at that? It's like, I'm a care of the elderly physician, I can't comment on that. And somehow I think that's what we've got to start to overcome. We've got to get people to be much more willing to question their colleagues and to see this as a collective good. If I'm running a GP practice, and I'll deliberately use that word running, because I think we have to have someone running a GP practice who then says it's my responsibility to make sure that everyone working in this GP practice, from the receptionist through to the practice nurse and the other GPs, are delivering high quality care.
So, I'm not going to try and summarise that, apart from to say, I mean, there's a core of this which is about defining value. And then there's a whole set of what sound like management and leadership skills that need to be applied to the system in a rigorous and relentless way. And one of the key themes that keeps coming back is the use of information from the patient, from the data, and feedback from colleagues and others. I think that's probably enough of a summary, because we have reached 1 minute past when we should have stopped. So I'll say thank you to the panel, thank you to all of you, and we're now off to the next session.